right? It's trauma to the nerves of the spinal cord. We're not going to talk about brain trauma here. That's a different thing. There are some unfortunate people who may break their neck or their back, injure their nerves, the spinal cord, and maybe their brain. But let's keep us focused now on the injury to the spinal cord nerves. CNS tissue at this point in medical science doesn't regenerate. So when you read, you saw that some people have what they call a complete cord transection, which means they have loss of sensory and motor, which is feeling and movement, below that level of injury, right? And if it's complete cord transection, it becomes a permanent loss of movement, paralysis, and feeling. Okay, so they're paralyzed below the level of injury. Don't worry too much about the incomplete cord transection syndromes. We're not going to talk about that. But it stands to reason that if somebody has some nerves getting through, they're going to have some movement and some feeling. So it just depends then on how many nerves get through and what they innervate, right? Okay, so for complete cord transection, they are paralyzed, unable to move and unable to feel below that level of injury. Always remember that above the level of injury, everything functions normally, right? So they have their brains, they have their intellect, their hopes, their dreams, their personalities. They have their cranial nerves. They have movement and feeling above that level of injury. So the higher the level of injury in the cord, the more that's going to be paralyzed below it. If we have the level of injury at the cervical vertebrae, how many vertebrae do you have in your neck? 7. C1 through C7 would be quadriplegia, right? Quadra or tetraplegia means 4, and plegia means paralysis, right? What's the medical term for weakness? Paresis. Right, paresis. So plegia is paralysis, paresis is weakness. So quadriplegia means there's some involvement of all 4 extremities. It doesn't mean they can't move their arms at all unless their level of injury is above C4. Okay, because you have C1 through C7. So a C1-2 person, quadriplegic, which is actually what Chris Reeve was. You'll see that in the video next week. He was a C2 ventilator-dependent quadriplegic. Why was Chris Reeve ventilator-dependent?
Because of the level where he was hit, it hits the respiratory, so his diaphragm doesn't contract.
His diaphragm doesn't contract. Okay, that's right. Why doesn't his diaphragm contract?
The nerves is damaged.
That's right, because the nerves leading to that have been damaged. What nerve is that?
The
phrenic nerve. PH, you said P. That's called phrenic. I had a lot of teeth removed. I'm going to be in a dental mess this semester while I get my Invisalign and my implants and all this expensive stuff. So if I lisp a little, it's because I have teeth pulled. The phrenic nerve, PH, RENIC, innervates the diaphragm. The problem with high quads is the phrenic nerve comes off the spinal cord. Anybody know where? Between C3 and C4. So if somebody has a C1, 2, or 3, and I mean cervical, 1, 2, or 3 spinal cord injury, their diaphragm the phrenic nerve comes off below that level, so it's paralyzed. It doesn't innervate the diaphragm. The diaphragm is your major muscle of respiration, isn't it? So they're not going to be able, if your diaphragm doesn't go up and down because your phrenic nerve is paralyzed, because it's below your level of injury, you're not going to be able to breathe on your own. So most people die from high spinal cord injuries. So it's a hangman's injury. C3 and C4, in that area. So a C1, 2, or 3 quadriplegic can turn their head, and that's about it. They need to breathe on a ventilator. A C4 quadriplegic might have some decreased tidal volume, some shallower breathing, but they're not vent dependent. And a C5, 6, 7 quad is not vent dependent. They breathe shallowly and they have a weak cough, which puts them at risk for what? Aspiration, but more importantly, atelectasis, pneumonia. They swallow okay, but they're at risk for pneumonia because of their shallow breathing. And in the reading, it talked about quad coughing, where you push down on the diaphragm as the patient goes, because the only way a quadriplegic can cough is to go, push up on the diaphragm. They get a good cough. Okay. Okay. So below that, a C4 quadriplegic can turn their head and shrug their shoulders. Because if you look at the dermatome chart in your chapter on neurologic assessment in the neuro section, which is what all these first couple of competencies are, is neuro, you can see that they have this innervated, so they can go like this. A C5 quad can turn their head, shrug their shoulders, and lift their arms up because they have biceps. A C6 quad can turn their head, lift their shoulders, bring their arms up, and also bring their arms down.
What level is that?
C6. You don't have to memorize this. You're not neurologists. But I'm making a point. When you're in embryologic development, and you can see this when you look at the dermatome chart, your arms grow out like this. So you've got C4, C5, C6, C7, C8, and then T1. And then there's how many thoracic vertebrae? 12. T1 through T12. So a T1 paraplegic, now we've got use of the upper body. So para means two, just paralysis. Paraplegic from T1 down, whatever's below that level of injury is paralyzed, right? So a T1 person would have problems with trunk balance, whereas a T12 paraplegic would not. A T1 person would have trouble with having a deep cough, and a T12 person would not. So why do quadriplegics and high paraplegics have problems with a weak cough? What muscles do you need to cough?
Your interest.
Yes, respiratory intercostal muscles. Between costals, the ribs. Your muscles between the ribs, your intercostal muscles, is what helps you take a deep breath and cough. So if you take a deep breath and cough, you're using those muscles. Those are voluntary skeletal muscles, aren't they? Right? So in a person who has paralysis of those muscles, they're not going to be able to take a deep breath and cough. That's why quadriplegics and high paras, people up with a respiratory intercostal muscle paralysis, remember below the level of injury is paralyzed, voluntary skeletal muscles. They're not going to have a good cough, and they're going to be at higher risk for developing pneumonia, atelectasis. Good. All right, so back to the scope of the problem. How many and what kind of patients do you think or people would be at higher risk of spinal cord injury?
Young men.
Young men.
European.
A large, European American, but young men is the main thing. Males under 30 years of age is something like 2/3 of people with spinal cord injuries. And then, of course, there are people older than 30, and sometimes kids. But why young men? Because developmentally, their brains aren't developed until they're 25, and I don't know how that explains up till 30. But it's the risk-taking behavior. It's the risk-taking behavior that's higher in young men. Young women, too. I've seen young women in these units. The part of your brain that controls judgment and impulse control doesn't completely develop until you're 25. So teenagers and young adults are at higher risk. About 12 to 15,000 people a year in this country have spinal cord injury. People can break their neck or their back without having nerve damage, right? Some people are lucky. They have broken vertebrae, they have fractures, but it doesn't go in and cut or damage the cord. But 12 to 15,000 people a year have cord damage. So we're talking here about the cord. We're talking about the nerves in the spinal cord being damaged, right? They can be damaged by, bone coming in and slicing it. They can be damaged by hemorrhage or edema, cutting off the perfusion, the blood supply to that area. So there's a number of ways that happens. Hyperflexion, hyperextension. What are some of the things that can happen to these people? Higher incidence in young men. It could happen to anybody. What are some causes of spinal cord injury?
Car accidents. Diving.
Okay, car accidents. The majority is motor vehicle accidents. Not just cars, but go motorcycles, right? One of my patients in the case studies, these were my patients in Boston when I worked on a spinal cord injury unit. Charlie was riding a motorcycle. Flew off the motorcycle, hit his head against a tree, and became a C5 quad. Okay? So, and then there's these all-terrain vehicles, snowmobiles, all these various kinds of motor vehicles. But that is the highest. Now, somebody also said guns, gun violence. That's a higher incidence, of course, in urban areas. But that is definitely a way to have spinal cord damage, if the bullet hits the spinal cord. Now, the most prevalent areas for quadriplegia and paraplegia are at the areas of the greatest mobility of the neck and the back. So most people, if they have a hyperflexion, in other words, somebody else said diving, or football, or some kind of sports injury, right, the ones where you get your neck snapped, is the highest place number is at the area of greatest mobility. So if you bend your neck forward or you bend it back, this is hyperflexion, this is hyperextension, that's around C5. If you bend your back, you lean down, you lean back, that's around T12 to L12. Okay, so that's where most of the quadra and paraplegias occur. But if it's a gun, the bullet goes wherever the bullet goes. So you'll see unusual levels like T8 or some kind of T9, wherever the bullet hits the cord. Okay, so those are the most common causes of spinal cord injury. Early management has come a long way over the years. And so the people are living now, like Chris Reeve, who would have died. Why would he have died if an anesthesiologist hadn't been watching his horse jumping competition and it responded? He would have stopped breathing. And he did stop breathing because he had a hangman's injury. That's how people die of hanging. They snap their neck when they drop and they stop breathing. Because the phrenic nerve is paralyzed if the injury is above C4. But somebody responded, did artificial respiration, got him to the hospital, intubated on a ventilator. He went for surgery. He had the fusion of the neck with the wires. He got a halo. All of that. He was kept alive. ABCs. Airway, breathing, circulation, fluids, blood, all of that to maintain a good blood pressure. And then he lived 10 more years on a ventilator as a C2 quadriplegic. Okay, and you'll see the video about the amazing human spirit that some people have. That self-efficacy. Now, he had a lot of things going for him, which we'll talk about next week, one of which, of course, was money. But he also had a lot of intellect and just, a great attitude. Okay, so we want to, who responds in the field? What do they do?
Airway breathing.
Yep, the EMS comes, right? The trained paramedics respond. They maintain airway, breathing, circulation. They put them on a backboard with a cervical immobilization, right? Nobody gets off that backboard and that immobilization until their spine films are clear, their neck and spine films. Now, obviously, if these people have neck or back damage, they stay immobilized. They go to surgery. They have reduction of the dislocation. The area is cleaned out. It's stabilized with whatever they need to stabilize it with. The metal for the neck, the wires, the rods for the back, Harrington rods, that kind of thing, if it's paraplegia. And then they go to an acute care area for a while and then to rehabilitation. And so these acute rehabilitation facilities like National Rehab or Kernahan's in Baltimore with the Maryland system do the acute rehab for people with new spinal cord injuries. And teaching them, as we talked last week, to achieve their maximal level of functional independence with whatever support and assistance they need. Okay? So, for stabilization, in Urigi reading, what did they talk about as the major stabilization for cervical injuries?
The halo fixation.
The halo, right. Anybody ever seen anybody in a halo? There's a picture in your reading. Mm-hmm. I saw a guy in San Diego, and I was working rehab there too, driving down the street on a motorcycle with a halo vest. Now, I'm sure that's how he got that halo in the first place. And he was fortunate enough not to damage his cord, or he wouldn't have been driving the motorcycle, right? But the halo vest, right? So that is actually skeletal traction. Remember the difference between skeletal traction and skin traction. Obviously, if you have a broken neck or a broken back, you've got to have serious traction. So there's 4 pins, right, actually drilled into the skull, and then there's metal rods that attach it to the vest, okay? And then the vest stays on until the neck has stabilized enough that they can remove it. I remember things, and that's called a halo. So it's what? It's cervical skeletal traction. And you all know why that's there. The nice thing about the halo is that it allows the patient to still be You know, they can still sit them up, put them in a wheelchair, take them to physical therapy. So it allows for earlier mobilization. I actually remember the old tongs and things, which they don't really talk about much anymore. But it was the same principle. It was like a little ice pick. You had two skeletal pins into the skull. Thank you. That's the word I was looking for. And then the weight hung off the back of the bed. The patient was in the bed. And then you could turn them side to side, lay them on their back. And over that 4, 5, 6 week, sometimes 8-week period, while the neck stabilized, they were in traction. So that's the same principle as this, to maintain stabilization of the cervical spine. Okay? So what happens, you have a little wrench on here, on the front of it's a fiberglass vest. So why do you think the wrench might be there attached to the front of the vest?
So you can use to remove it.
So you can remove it. You're going to take it off to clean? No. Why would you need to remove the vest? Why would that be sitting there in case you need it?
In case you need to do like resuscitation.
In case you need to do resuscitation. Exactly. So say your patient's up in PT, he gets short of breath, he throws a pulmonary embolus, and he codes. Can you do chest compressions through a halo vest? No. No, it's made out of fiberglass. So in that case, you would need to remove it, do chest compressions, go for the emergency resuscitation. Exactly. All right, and these would be tongs, same principle, named by whichever neurosurgeon invented them. Gardner Wells, Binky, Crutchfield, those guys had this system. And now we mostly use the halo because it improved its earlier mobility. Because when people that are quadriplegic sit up fast, what are they prone to? Orthostatic hypotension and syncope, right? Why? Because their blood doesn't come back from their legs because you need what? Push your blood back up. Skeletal muscles, which are paralyzed. So for the rest of their life, they're going to be at risk for orthostatic hypotension if they sit up too quickly. It takes a while to get them up to a sitting position. What would happen if you took the patient you put them in their wheelchair, this used to happen to us in Boston, put them in the wheelchair, all my friends that work there are stuck in the hospital right now because they can't get out. You put them in the wheelchair and all of a sudden you look up and look over and they're out. What do?
You lay flat. You lay them flat.
Whoops. Take the chair, lean it back till their head is below the level of their heart and wait for them to come back. Well, I mean, you're still, with them. You're taking their blood pressure and stuff. But that usually works. Instead of fooling around trying to get help, get them back in bed, put the head of the bed down, blah, 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 you just pull the chair back. Same principle, right? Mm-hmm. By the way, do you think Trendelenburg works for people in shock?
Yeah.
No. We don't really do Trendelenburg anymore. What's Trendelenburg?
When your head's down.
When somebody passes out, you put their head below the left, you put them like that. We don't do that anymore. We just put them flat with their legs up. Evidence-based practice. Okay. So, yes. Questions?
If you break a vertebrae or something in your back and you have surgery to fix it, how soon after surgery can they sit you up? If you have like a thoracic injury?
It depends. See, that's always the answer you're going to get. It depends on a lot of different variables. I'll tell you that the spinal surgeries in a place, well, everywhere now, they're usually up the day of surgery. They're usually up in the chair, out of bed the day of surgery to prevent immobility because they only get maybe 48 hours in the hospital now and then they're home.
Okay.
For the regular, fusions.
Okay.
Say they have a lumbar fusion for back problems. They're usually up the day of or the day after. They're at least sitting in the chair and sometimes walking with PT. And then they're gone. So for the thoracic paraplegics, your book said that they have different kinds of rods they can put in. We're talking now again about stabilization. They need some sort of traction or rods, like Harrington rods, which are surgically put along the spinal cord, wherever level. Or they have these orthotics. What are orthotics? What's an orthotist come in and do?
An orthotic is like some kind of device that
Helps to stabilize or, a brace or something. Good. So they can develop a brace. They can fit the patient for, say, a Kydex jacket, which is like a fiberglass turtle shell with a front and a back and Velcro straps. And when the patient's flat, You roll them up, log roll, put it on the back, roll them back, put the top on, hook the Velcro, and then start to sit them up. And again, while that jacket's on, it stabilizes the spine so it doesn't move. Okay? Along with the surgical rods if necessary. You see those rods sometimes for scoliosis, don't you? To straighten the spine. They may be temporary, they may be permanent. All right, let's talk about spinal shock and autonomic dysreflexia. At the time of the injury, it's a very severe physiologic stress to the body, right? Now I said that at that level of injury, they will permanently lose, unless they have some nerves that get through, a feeling and movement below that level, right? Okay, so that doesn't change. The voluntary skeletal muscles are absent from that time on, voluntary skeletal muscles. But what else happens at the time of the injury is they also lose their spinal reflexes, the reflexes that go right through the spine and back to the end organ. Okay, so it says the person's quadriplegic. Anybody with a cervical injury is going to be quadriplegic, right? So over here, it didn't erase very well. Says it's a dry erase. Say you have the bladder, the bowel, the penis, all of that. You're going to have reflexes that go from the bladder when it's full or the rectum to this S2 through S4 part of the core. Did you read that part, the VSS supplement there in the appendix? There's a good one on autonomic dysreflexia. And actually, Iggy does a pretty good job on autonomic dysreflexia with her explanations and charts. But also, when we talk about neurogenic bowel and bladder, you've got to know where in the cord that reflex arc is. Okay? So let's say the patient has a C5 injury. Okay, so from that point on, all the voluntary skeletal muscles, you know, the things where you say, move my foot, and the foot moves voluntarily, those are gone. But during spinal shock, those spinal reflexes are also absent. It lasts from the time of injury to about 3 to 6 weeks post-injury. So the patient will have an atonic bladder, which means it's just going to be uninhibited and fill up, right? So they'll probably need a Foley catheter. You want to remove the Foley catheter as soon as possible and start bladder training, right? Why? Because of the risk of UTI. It's actually less risky to take the Foley out and do intermittent cath than to leave the Foley in. Okay, but during spinal shock, the bladder's atonic, it just fills up. And of course, that's a risk. Why? If your bladder just fills up, you can get reflux, you can get hydronephrosis and kidney damage. Also, at the atonic bowel, they may start out with a paralytic ileus. How do you know somebody has a paralytic ileus?
No.
No bowel sounds, right, good. Nothing moves, so they would be NPO, maybe even with an NG tube to low suction. Then you would take the NG tube out once they have bowel sounds, and you would start to feed them. Muscles flaccid? The muscles will stay flaccid below the level of injury, the voluntary movement. But at the end of spinal shock, the involuntary spinal reflexes below the level of injury will return. Okay, so here's your critical thinking question. If you read and thought about it and looked at your notes ahead, how do you know when spinal shock phase has ended? You'll know because some of these involuntary spinal reflexes that had been absent have now returned. Not the voluntary stuff, but the involuntary spinal reflexes. Can you give me an example of maybe something that would come back? Not so much bladder control, because I'll have a neurogenic bladder, so they'll always be incontinent. Okay, but here's a couple things. So you go into the patient's room, say it's 4 or 5 weeks after their injury, and you've been doing intermittent catheterization. Say it's a 28-year-old male. And as you're doing the intermittent cath, you're obviously holding the penis and inserting the catheter. So all the other times, the penis has been flaccid in your hand. This time, with tactile stimulation, it's not psychogenic. He doesn't know it's happening until he looks down and sees it too. It's reflexogenic. The reflex arc returns, and the penis becomes erect from tactile stimulation. Same thing that happens with a little baby boy when you change his diaper. It's all tactile stimulation. And that wasn't happening before because now that reflex has returned. Or the patient you've had to cath them to get the urine out, and now when you go in, you realize that their bladder has automatically let go. not continently, but at a certain fullness it has reflexively emptied. Or you're putting a suppository in for to do a bowel program. I think they've gotten away from a lot of the amount of digital stimulation we used to do. But we used to put the bowel, and sometimes you still do it. You put the suppository in, you put it into, for an insertion of a suppository, in through the external and internal sphincter, and then it melts. So you're going in half an hour later and you're going to do digital stimulation for the bowel program. And before, when you put your finger in to put in the suppository, it was flaccid. Now when you put your finger in, it closes around your finger. That's actually called an anal wink. I did not make that up. A-N-A-L-W-I-N-K. Because when you push it in, it closes around your finger. See the wink? All right, that's the internal sphincter. That's the spinal reflex returning. Or you go in with the tray and the patient's foot is jumping, or feet. And he looks down and he goes, wow, I'm going to walk out of here. I can move. Well, unless he's doing it voluntarily, it's a muscle spasm. So the spasticity has begun. Those are spinal, involuntary spinal reflexes. Spasticity can become a real problem. They may need to go on muscle spasm medications like baclofen, Dantrium, Valium, some of those, Flexeril, Soma, because of the muscle spasms. Or I saw a PT once teach a patient to hit their leg till they got a muscle spasm and then reach down real quick, put their shoe on. They actually made the muscle spasm work for them for ADLs. But that's the return of those involuntary spinal reflexes. That's how you know that the spinal shock phase has ended. That doesn't mean the voluntary, they won't have a continent bladder, continent bowel, or voluntary movement, but they'll have the involuntary spinal reflexes return below that level of injury. It's still cut off from the brain. Just give them a brain. Okay. All right. The other concept, which hopefully you read up on in the book and also in that supplement in your appendix. This is a NANDA nursing diagnosis. It's called autonomic dysreflexia or autonomic hyperreflexia. And this is where you'll study it, is this competency in this course. You'll probably see questions about it or spinal cord injury on, Kaplan tests and on NCLEX. But this is something that's kind of a specific medical emergency that you would see in quadriplegics and high paraplegics. So you C1 through C7, T1 through T12. Below that is what? L1 through L5, followed by the sacral vertebrae. Let me point out something to you while we're doing this. So back under the stuff in the back, page, anybody got a page for me for the competency 2 stuff? It's back around, page 210 in the back is autonomic dysreflexia. Okay. Page 211 is autonomic dysreflexia, page 212. 13, 14, 15, 16, 17 is neurogenic bladder. Then there's some case studies. All right, and that's it. But the thing on dysreflexia is good. Now, back to competency 2. Maybe it got back in here. Competency 2. Okay. The regular competency 2 information is on page 23. Page 24, then there's a outline, and then page 27 is one of the case studies, Charlie, who was, again, my primary care patient in Boston. It was really good to use primary nursing in that model because we got to know these patients really well over a long period of time. Page 28 is the terms. Page 29 is a picture. Okay. Page 30 is a picture on autonomic dysreflexia. All right, so it's related to or due to a massive discharge of the sympathetic nervous system with no control by the brain, by the CNS, the central nervous system. So if somebody has a noxious stimulus, something that for all of us we would notice and know what it is and fix it, they don't know They just have a physiologic response. And the physiologic response to sympathetic nervous system stimulation is what? What happens when you stimulate the sympathetic nervous system? You have an increased blood pressure, right? You'll initially have an increased pulse. We'll get to that. If you have severely high blood pressure, quads tend to have low blood pressure, but they can get really high, hypertensive emergency during autonomic dysreflexia. Something is overstimulating the sympathetic nervous system. So if you have a really high blood pressure, and I'm talking like, 250 over 200 or something really high, what can happen? Well, first of all, you're going to have a headache, a bad headache. You can also stroke and die, right? That. You're above the level of injury. You can vasodilate. You can flush. You can sweat. Below the level of injury, none of that happens. So vasodilation is a compensatory mechanism to try to decrease the blood pressure, but that only happens above the level of injury. They're going to have the flushing. They're going to have the sweating. Patients with spinal cord injury only sweat above their level of injury. So that's why patients that are quadriplegic, the higher the injury, the more at risk they are for problems with body temperature regulation, because they don't sweat in the heat, so they get hyperthermic. You're not able to keep their bodies warm in a cold weather. You go out in this kind of weather and sit out there for a couple of hours, and you're quadriplegic, you can get hypothermic. I mean, anybody can today, but they're more at risk because of those lack of those things below the level of injury. Okay, so the other thing the body does, remember above the level of injury is normal. In your reading, it talked about initially the blood pressure goes up and the pulse goes up. But then what in the brain still functions to lower the pulse to try to lower the blood pressure?
Vegas.
The vagus nerve, exactly. The vagus nerve, which is what? One of the 12 cranial nerves. And I still don't really know them real well. I just know on Old Olympian towering tops of Finn and German viewed some hops. And there's another one that's more off color. To touch and feel, but I don't remember the rest of that. But anyway, the V, viewed some hops. The V is the vagus nerve, right? You study the cranial nerves. And what does the vagus nerve do? It decreases the heart rate, right? Vagal stimulation. Somebody does that and they don't want to, they can get vasovagal and pass out. But the vagus nerve compensates in this case, because it still functions, to try to lower the blood pressure by lowering the pulse rate. Okay, so that's why you see bradycardia in autonomic dysreflexia. So the noxious trigger is something that overstimulates the sympathetic nervous system. So the most common cause is what? Related to, it's up there.
Bladder.
A full bladder, right? An overdistended full bladder. So you need to assess that if somebody has autonomic dysreflexia. One of the most important, I'm not going to say the first thing you're going to do, but one of the most important nursing interventions would be to find the stimulus that's causing it and remove it. Find the problem and fix it. Then it goes away. So if a patient has a really full bladder, you can assess for that. We have bladder scans now, or you can just do your own assessment. They may need to be catheterized. They may need intermittent catheterization. Quick story, had a student at Greater Southeast, which I actually worked at for 7 years in education, but this was a clinical group. We were taking care of a guy who was a quad. He'd been a quad for a number of years. That's the ones you see in med-surg. He's back in for UTI. He had a 3-way Foley with a continuous bladder irrigation. So the bladder irrigation's going drip, 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 drip. Student comes to me. She said, Mrs. Eng, the CVI is dripping in, but the Foley bag is empty. I said, oh, that's not good. She said, nothing's coming out. I said, oh, okay, let's go investigate. So we went and looked at the patient. He's got little beads of sweat. And I said, do you feel like you have dysreflexia? And he said, yes, I have a headache, whatever. So I turned to the student. This is kind of a trick question. I said, okay, what are you going to do first? Well, the right answer in this case was to turn off the bladder irrigation, because it's going drip, 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 and it's not coming out. So it's going to make any problem worse. It's not an IV. It's not going to clot. Turn it off. So she shut it off, so it wasn't continuing to go into him. And then I said, now what are you going to do? And she just kind of looked at him. And I said, we can get vital signs and stuff. I said, I'll do that. So I'm getting his vital signs. Of course, his blood pressure's high. And so I'm making the nursing diagnosis autonomic dysreflexia related to some problem in the bladder. So she's looking at him. And I said, I'll tell you what we need to do. I said, since nothing's coming out of the Foley, why don't we follow the Foley tubing back up to the patient's bladder and see? And she looks at him, and it's under his butt. So we take the patient, and we turn him up. Remember, he's a quad. We turn him up on his side, and guess what? It's kinked. It's under his butt, and it's kinked closed. Boop! That was the problem. And she looks at it, and she goes, well, I guess I thought he would. Oh, that's right, he can't feel. And then maybe I thought he would, oh, that's right, he can't move. So we unkinked the catheter, pulled it out from under the patient, ran it down into the bag, problem was solved. Okay, but he could have died because he was a quad, and we were not only was it kinked, but we were dripping in the CBI, making it worse. So as soon as we unkinked the Foley, so that's when you hear in medicine and nursing. You ever heard the statement, look for horses before you start looking for zebras? Look, so what it meant was, it was just a kinked Foley. It didn't. Now it might not have been. It could have been something else. If it's not bladder, then it could be a full bowel. That will also cause this. So then you check the bowel. You may need to do a disimpaction or a bowel program. If it's not that, you can check the skin. It might be they're lying on something that they don't know they're lying on. Or you can, check to see if they're having skin breakdown or just their shoes are too tight. Okay? All right, so next one says priority order. Now, if you read Iggy and you looked at that little chart, when you think about it, once you've assessed, you always have to assess first, right? You got to assess. You got to figure out it. And in nursing, with experienced nurses, the nursing process, the steps are all happening kind of boom, 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 right away. Patient's in trouble. This is what I see. This is what he says. Objective, subjective data. Grab a blood pressure. Do something. Make a diagnosis. Do something. So the first thing you can do in a spinal cord injury patient to try to lower their blood pressure, because remember it's emergently high, is what? Sit them up. If they're not, even in the halo, sit them up and dangle their legs. So when you sit the patient up, what does that do? What are you going for in this case? You're going for an orthostatic hypotensive effect. You know that they're at risk for that, but in this case you want that. So you're going to sit them up to try to get their blood pressure to drop a little bit. Okay, you want them to become less hypertensive. You don't want them to become hypotensive, but you want them to become less hypertensive. And sitting them up will help. And then what are you going to do?
Loosen clothing.
Okay, you could do that. All right. Now I want to start doing what? We just talked about.
Assessing.
Tubing.
No, you're doing something now. You're doing something now. I mean, you're assessing while you're doing. I hear what you're trying to say. But what would you do next?
Stop. Find the source.
Find the source. Find the problem that's causing it. And fix it. Find and remove the noxious stimulus that's causing the dysreflexia. So the first thing you check is the bladder. If that's not it, if it is, fix it. If that's not it, what do you check next? Bowels. I see what you're saying, going with assessment. Fix it. If that's not it, check the skin. Okay, now what if none of that works? What have you also been doing during this time? If you're in a rehab facility, you're going to have standing orders. You're going to have a dysreflexia protocol. And you're going to have a lot of things that you can do as a nurse. But you're not doing it alone, right? In a medical emergency, who are we in communication with? The physician, the doctor, somebody who's the healthcare provider, the rapid response team. I don't know. You're not doing it by yourself. You have to communicate. You have to get orders or follow the standing orders and get those signed. So, when somebody says, when do you call the doctor? Well, it depends. It depends on what unit you're on. It depends on, how sure you are of what's happening. I'll tell you, if a quad or high para has had dysreflexia before, they're going to know it, and they're going to tell you what it is. So listen to your patients. If they're telling you that they know what to do, they're probably right. It's like a patient telling you they're in pain. Don't argue with them. It's what they say. Okay, so in this case, you're all contacting the doctor because the patient's got a sky-high blood pressure where obviously something's wrong. You're in communication with the doctor. At least at this point, you need to be in contact with the doctor Because the next step would be to give rapid-acting antihypertensive medications to bring down the blood pressure. But you got to make sure that you really need them. Because what would happen if you gave somebody nitroglycerin sublingual or nitroglycerin paste? What does nitro do? How? Vasodilated, right? It's a vasodilator, so it's going to dilate the blood vessels to bring the blood pressure. Or a Presaline or Cardizem, some of these that you can give like under the tongue, or IV even if necessary. In rehab, we don't often have IVs in people, but some kind of rapidly acting antihypertensive. But what if you gave them that and then fixed the problem? Then what are you going to have? You're going to have a patient with no blood pressure, right? Because now you've normalized their blood pressure by fixing it, and you've given them something to lower it more. So we're careful with that kind of thing. That would be if you can't fix it. Okay, then you would need to go to the meds. Along in collaboration with, it's a collaborative problem because it's a medical emergency. Nurses do not intervene independently in medical emergencies, right? Okay. So that's autonomic dysreflexia. What it is, how you assess for it, what are the assessments, signs and symptoms, and then what's the nursing interventions, what do you do?
So if you have a patient who has autonomic dysreflexia,
These are episodes of this, yes.
but you can't find the source, would you hit the code for something?
You could.
Okay.
You could. Yeah, rapid response. If you're in a facility that has a rapid response team, that would trigger a rapid response. You're not dead, but you want to keep them from having a code. So if you don't have rapid response, you could call it code, but they're not actually coded. You see what I mean? You're trying to prevent that. So that's why they instituted things like rapid response teams. But I would definitely have the house officer, the resident, wherever you are, whatever it is, there by the bedside pretty early in the process. Yeah, don't try to handle these medical emergencies on your own. Yeah. I always thought I had to too, but you don't really. You have to. That's why communication is so important. Okay, so who's at risk for alteration in respiratory function?
Cervical.
The higher the level of injury, the more at risk they are, right? Because somebody who has shallow breathing and a weak cough because of their respiratory intercostal muscles are paralyzed would have difficulty with airway clearance. So it's really important that they have good respiratory care, aggressive, what they call pulmonary toilet. I don't know if you hear that word anymore, but aggressive respiratory care, somebody helping them with incentive spirometer. We had a young male RN, great guy. He was the director of nursing at National Rehab when they first opened it. He used to come in the morning, and the guys whose necks were stable, I mean, they weren't in tongs or halo, he would pick them up, turn them upside down, and shake them. Hey, it worked. It was like postural drainage, right? All that stuff that had settled all night loosened up, and they could bring it out. It was pretty cool. We don't do that anymore. But it was actually an effective intervention. He was also very strong, because some of those guys were big. I didn't do that. Altered breathing pattern. Again, they have shallow breathing and a poor cough, which can lead to impaired gas exchange. So I read an Iggy, it said actually that pneumonia and respiratory complications is now the leading cause of death in people with spinal cord injuries. So the higher the level of injury, the more they would be at risk for that. And if their injury is above C4, now what do they need?
Ventilator.
They need intubation and ventilation. Okay, so short term, somebody on a ventilator has an endotracheal tube. If they're going to be on that ventilator long term, what do they have to get? What do they have to put in? A tracheostomy. So when you see Chris Reeve, you'll see the vent, you'll see the trach, long-term vent dependent because the phrenic nerve and the diaphragm are paralyzed. But even other quads and high paras have problems with deep breathing and breathing. If their injury is below the respiratory intercostal muscles, they're probably not going to have that much trouble with that. They'll have other hazards of immobility, but not so much that. Okay. So you have to know how to suction the patient who's on a vent, the family has to know, the caregivers, etc. Obviously, alteration in mobility. They're, no longer necessarily able to ambulate. Now, the people with really low levels of injury, like in the lumbar sacral area, they may be able to walk with braces, or even, so in embryologic development, the arms grow like this, with the dermatomes, and the legs actually go like this. So the very bottom of the patient is the perineal area. So when you get down into the lumbar and sacral vertebrae, the very bottom is this cauda equina where the bowel, bladder, and penis, etc. are innervated. The perineal area is actually the bottom. So you've got like, L1, L2, L3, L4, S1, like that. So a patient with a really low level of injury, like Neil, one of your cases, if you read the case studies, actually fell off a roof and he had a low injury. So he actually walked out of the unit with a small brace. They called it an ankle-foot orthosis because he had foot drop. But he had a backpack full of catheter kits because he had a lower motor neuron neurogenic bladder that was flaccid and wouldn't release or let go. So we'll talk about that. Okay, you can see wheelchair mobility, and I don't need to get into all that, but you know these days there are hundreds of different kinds of wheelchairs for people who are wheelchair bound permanently. And there are all kinds of fancy ones. And you'll see the one that Chris Reeve has where he moves around with a puff straw, and it can turn and go back and forth and even lay him down. They have the ones with the projections for the people who don't have good hands, but they can do this. They have, of course, somebody that has good full use of their hands, like a paraplegic can roll the wheelchair like this. Then they have wheelchairs for marathons, for basketball, for the beach. They're titanium, they're lightweight. There's all kinds of different things people can do. Again, depending on their insurance, depending on how much money they have. I think the one that Chris Reeve had was probably several $100,000. Because it had the ventilator on the back and all that sort of thing. But he probably also had really good insurance through the Actors Guild. The tilt table is just something that PT can put the patient on. Chris Reeve did this too. Every day they would put him on a tilt table, strap him in, and then they would start to raise it up. And it would tilt up. And they would go a few degrees, take his blood pressure, let it settle, a few more degrees, and they got his body used to the upright position. Because we know that the kidneys drain better, the lungs do better, the brain does better when people are upright. So he was trying to maintain, through exercise, the swimming pool where there's no gravity, all these kind of modalities to maintain his muscle tone, so that he was hoping when they learned how to put CNS tissue back together, he would be one of the people to benefit from it and he could walk away from his wheelchair. That didn't happen, but the research continues. And he was a good advocate for that. All right, the last thing I want to talk about really in any detail here, because I'm going to just keep going until I give you a break, and then we're going to have a break, and then we're going to take the dosage thing, is neurogenic bladder. So, remember I said that a patient who is spinal cord injured has a neurogenic bladder. That means they don't have a continent bladder. There's some disconnect to the brain that says, oh, my bladder is full, but I can't get to the bathroom until 10:15, so I can wait 15 more minutes. There's no voluntary continence, okay, in a neurogenic bladder. There's like 5 types of neurogenic bladders, but I'm not a urologist, and really we're only talking about the ones that are related to spinal cord injury. And again, you have a nice explanation in your appendix there. A person who has an upper motor neuron neurogenic bladder has an injury above the reflex arc. Remember, sacral, that's very low. It's the last part of the neural tube to close in embryologic development. So this is where you'll often see problems in babies with neural tube defects called spina bifida myelomeningocele. Okay, we're not talking about that, but it's the same principle. In upper motor neuron neurogenic bladders, the level of injury, these are all neurogenic, whether it's upper or lower, would be above the reflex. So that's a lot of things. All quads, anybody with a thoracic injury, anybody with a lumbar injury, all the way down to this S2 through S4 cord levels, what we call upper motor neuron. This is what we call a spastic bladder.
So the injury level is above
Anything up here.
S2?
Yep. Which is most people, the spinal cord injury. So most spinal cord injured people have an upper motor neuron spastic neurogenic bladder. So what will happen is that at a certain fullness, it'll trigger the reflex and it will just incontinently empty. They'll just void at a certain fullness. That's a good thing. The bad thing is it's a reflexogenic, so it's not continent, but it's reflexive. At a certain fullness, it will reflexively incontinently empty. The problem is it doesn't empty completely. So they can have what we call high post-voiding residuals. So somebody with a high post-voiding residual, we see this in old ladies sometimes in the nursing home, right? They don't pee out everything. What are they at risk for? UTI, right. And how do we know after a person voids, even incontinently, how much urine is left in their bladder?
Bladder scan.
We used to actually have to cath them. Now we use a bladder scanner, right? And you see how much. There may be, actually they consider anything under 100 mLs to be okay in a neurogenic bladder. So an upper motor neurogenic bladder reflexively empties, and that's where it's up on the slide too. Reflexive, it spastically empties at a certain fullness. The problem is you're trying to get it to empty completely. So one of the goals of the bladder training program is to maybe give medications to help them empty better, drugs like urocholine, to be able to eventually have them empty well enough that they can wear condom drainage, or which is nice for men, the condom drainage to the leg bag or the bed bag. They have good condoms, not those old things you use in the old men in the hospital, but good condoms. This is stuff from spinal cord injury literature. But women, unfortunately, have to wear Depends because we don't have anything to really hold on to get a good external urinary collection system to stay on and not leak. Yeah?
Yeah, if the bladder doesn't empty completely, would the person have incontinence?
They are incontinent. They're incontinently emptying. They're already incontinent. We're not changing the incontinence. What we're trying to get them to do is incontinently empty better so that they can wear external collection and not be at risk for UTIs. If they're not incontinently emptying well enough, we might have to do intermittent catheterization. If we can get it to incontinently empty well enough without a high PVR, we might be able to not cath them, but just let them wear condom drainage. If they were continent, they wouldn't need condom drainage. But a neurogenic bladder is an incontinent bladder. So we have two types. Okay, so the spastic reflexogenic bladder is any cut off to the brain, but above the level of the reflex arc, which is S2, S through S4, sacral cord, right? Here's the area of the cauda equina. It's very low. Now, for some small number of people, and there's one patient in your case studies, Neil, who I remember, I said walked out of the unit with a backpack full of cath kits. That's kind of a visual. I don't know if he literally had a backpack full of cath kits, but I think he did. He had a lower motor neuron neurogenic bladder. So his bladder was also incontinent, cut off from the brain, but it was flaccid and areflexive because the level of injury injured the reflex, right? So this is the lower motor neuron. And so this one, instead of being spastic, it is, what's the opposite of spastic? Flaccid. And instead of being reflexive, what's the opposite of reflexive? Areflexive. And if you have an A in front of the word, what's that mean to you?
No.
It means not. It's not reflexive. It's not going to set off a reflex and empty automatically because the reflex is damaged. This automatic spinal reflex in the sacral cord. So these patients would be at risk for what? If they're going to just fill up, they can get reflux. That's another different word. Don't confuse reflex and reflux. Reflux means that it's going to fill up, go back up to the ureters, and cause hydronephrosis and kidney damage. So they're at risk for renal failure. Actually, all people with spinal cord injuries are at risk for renal failure over time, especially if they have a lot of kidney damaging, stone forming, resistant UTIs. Charlie, I'll tell you now, died of renal failure from a resistant Proteus UTI that he got in our unit in Boston. Because the hospitals are the ones with the meanest, most resistant, hard to treat. We gave him every antibiotic over the 2 years he was alive post-injury to try to knock out that infection, and it didn't work. So he did die of renal failure. And not just renal failure, but also sepsis. And that's actually how Chris Reeve died. He died of septicemia secondary to dermal ulcers, to bed sore infections.
So you're saying it just fills and fills and
Just
fills
fills
and
up.
won't reflex?
That's right.
Okay.
Now, there are some times in some patients, I'm just trying to give you the very basic physiology, where they can make themselves go. I think Iggy even talks about some of that. Don't worry about that. They can do Crede, which is putting their hand on the bladder, or tap. There are some things stroking the thigh. Some patients can get some of that, but mostly in this case, that's not going to happen because the reflex isn't there to be stimulated. Okay.
But even if they do this, they're going to have the high volume.
Yes, they're going to still have a very high volume of urine sitting in their bladder. So what we taught Neil was intermittent cath. He had good use of his upper body. He was intelligent. He could use his hands. So he knew that, during the day he cathed more often. After 6 o'clock at night, he didn't drink, so he didn't have to wake up in the middle of the night to cath. If he was out drinking beer with his buddies, he had to cath more. He learned how to manage his own intermittent cath and his own lower motor neuron and neurogenic bladder. Exactly, you got it. The neurogenic bowel is basically the same principle. It's neurogenic, so they're not continent, so they need a bowel program. So they still have the gastrocolic reflex that everybody has after we eat. A warm cup of coffee, a nice meal. 30 minutes later, if necessary, they do a suppository. Put the suppository in, Dulcolax or glycerin, let it do its thing. Got to give it some time to work. Then it works better if they sit up. If they can't, they can do it in bed on their side with chucks, or the caregiver can do it. We try not to do a lot of digital stimulation, but that may set the reflex to go. So if they have an upper motor neuron neurogenic bowel, you can stimulate the reflex. You can stimulate the reflex, and then the stool will come out. And that's what you want. The outcome measure is the patient will completely empty their lower bowel, because you want it complete, don't you? Because they're incontinent. So if you don't get a complete emptying, they're at risk for a bowel accident when they're at work or school or whatever. Okay, you want them to regularly on a bowel program. So it might be every morning. Some guys like to do it at night when they have more time. You try to make it closely approximate their pre-injury bowel pattern. The lower motor neuron neurogenic bowel is actually the same kind of bowel program, but in addition to the suppository and the digital stim, you may need to do manual removal. If they don't have the reflex, they're not really going to get a good reflex emptying. But again, you're going to use food, a hot cup of coffee. I was going to say a cigarette, but we don't encourage that. But that works for some people. Sitting them up and that sort of thing to get a good bowel emptying. So they have to have, how to make people have good bowel movements and prevent constipation. You teach them to do what?
Fiber, increase.
Drink a lot of fluids, good fiber, regular movement, etc. All right, only thing I want to say about alteration in skin integrity is these are the people that are at the very highest risk. Remember the risks of immobility. These people are immobilized. If you can't feel and you can't move, then you're at extremely high risk of dermal ulcers. Decubitus ulcers, bed sores, whatever you want to call them, same thing. Patients who are less nourished, have poor protein stores, low blood albumin levels are at higher risk. Even if you do what? What do you do to prevent it? Turn. Night shift. Everybody goes this way. At midnight. 2 o'clock, everybody went this way. I'm not making this up. 4 o'clock, everybody went this way. We had 16 people. It was actually nice because we had a big ward and all the young guys were in one room together. That would be horrifying to these private hospitals now with all these private rooms. But it worked really well for these young quads because I could feed him, scratch his nose, do something over here, go back over here. I could have 6 patients, and they were all between here and here. And they liked it because they could talk to each other. Anyway, those days are gone. Now the nurses have to work 500 blocks down to the last patient on this huge, Anne Arundel. Those rooms are big. Those nurses walk a lot. And plus those little old people. Now it's better for HIPAA and it's better for infection control. But some of these elderly people that are really isolated down at the end of the hall, it actually increases their fall risk. If they had a roommate, they would be actually safer. But, I get the patients like them, and it's HIPAA and infection control. Okay, so prevention. If it happens, and sometimes you can't avoid it, It has to be staged. It has to be aggressively treated. And sometimes these patients will have had multiple myocutaneous flap surgeries over the course of their lifetime. You know, their butt looks like a road map. They had here, and they had here, and they had here, and they had here, and they had here, right? And they've had a lot, there's hardly anything left to flap by the plastic surgeon. So we want to prevent it because it costs a lot of loss of work time, school time, money, etc. Big deal. Sexual expression. Okay, so what do you want to say? What do you want to know about sex? You want to know what people that are spinal cord injured can do. It's always a fun topic. We don't have much time to talk about it. But it's interesting. There are specialists in these rehab hospitals where they do have people that can do sexual counseling for couples, people that have spinal injuries or are disabled in some way. Because all people are sexual beings, all genders, all sexual preferences, all age. But sex means different things to different people, different cultures, etc., right? Different genders. So you want to be in sex counseling when the patient has some behavior or asks about it. That may not be in the first 24 hours when they're on a ventilator in the neurosurgical ICU. But if you're their rehab nurse, you know, a couple weeks or months later, they may trust you enough and they want to talk about it. So the first thing in the PLUS model is it's okay to talk about it. You do not giggle and run out of the room. Permission means you don't say, I permit you to discuss this. It means you let them know it's an okay subject and you're willing to talk to them about it in a professional way. And then you listen. What's the patient really asking? What do they really want to know? It's like my daughter told me that when she first asked me about sex, the birds and the bees, she said, I was too young for the amount of clinical information you gave me. I said, well, that's because your mother's a nurse. It's an occupational hazard. Well, I know, but I didn't need to know all that. So some of these kids, they're kids to me now, in these case studies, maybe Scott just wanted to know that somebody would still find him attractive and some girl would love him someday, instead of, the whole explanation at 15 the first time he asked the question. You need to know what they really want to know. Then you do provide accurate information. That's assuming you have accurate information. And then there are specialists and people that you can refer them to. So a patient whose upper motor neuron neurogenic bladder may also be able to have a reflexogenic erection with tactile stimulation. Because again, the reflex is still working below the level of injury. So, we have your bowel, we have your bowel, your bladder, we also have a penis, right? Okay? All of those things can have a reflexogenic erection if it's upper motor neuron and the reflex is intact. Sometimes that can be used in sex counseling, etc. The men many times are sterile, and that's because, remember, I think about Seinfeld. You guys are from other countries. But in Seinfeld, they had this one episode where it was called shrinkage. The testicles in the cold weather will pull up to protect the sperm, and in hot weather will drop down to keep them temperature, because sperm need a very narrow temperature range for viability. So in the cold, they pull up to keep them warm. In the heat, they drop down to keep them cool. That doesn't happen anymore in somebody with spinal cord injury. There's all kinds of fancy things they can do now with, reproductive technology to remove the sperm, inseminate the partner, the woman, if it's a male-woman thing. Okay? And they can have reflexogenic erections and some things they can do. Or we'll get into this with the case studies. I don't want to spoil some of the good stuff. But Charlie was 23, Scott was 15, and Scott said, I'm never going to be able to have sex. I've never had it, and I'll never be able to. And Charlie said, well, think of it this way, at least your tongue's not paralyzed. Which was probably too much for a 15-year-old boy, but Charlie was making a point about alternative methods of sexual expression. And if you've ever seen some of these movies, really old movie called Coming Home, Jane Fonda and John Voight, he's paraplegic from Vietnam, in a wheelchair, and they show this sex scene, and he's paraplegic, and they're having oral sex, and anyway, it kind of proves that the guy was still sexy even though he was a para. Anyway, but that's the point I'm making. It's an important point, because there are other things. Now, so the men tend to be sterile, but the women still will do what, generally? Ovulate, which means they can get pregnant, and they do. Spinal cord injured women have gotten pregnant, carried to term, and had normal vaginal deliveries. They have spinal anesthesia, so they may not know when they're going into labor, or they may do a C-section, and they are considered high-risk OB. And they're high-risk OB because of the risk of UTIs and that sort of thing. But they would need contraception if they're trying not to get pregnant, and many of them are trying not to get pregnant if they're sexually active. So what do you think the best type of birth control would be to recommend for her, for contraception? Okay, so let's go through it. What about the hormonal methods? The pill, the depot, any of those things that are hormones. Why do you think it might be contraindicated for a spinal cord injured woman to get hormonal contraception?
Hypertension.
Clotting. These people, for I hope obvious reasons, are at risk of DVT. Remember, their leg muscles don't work. So they're very high risk of DVT, which if they break off and travel, can become what? Pulmonary emboli. And they have had people die. There was a football player who was doing his rehab in Miami. They have a big spinal cord center in Miami. And he was doing great in his rehab, and he threw a PE and died in therapy. They're at risk for that. So sometimes they'll put them on a blood thinning protocol, an anticoagulant protocol, because of the risk of DVT. So because of the risk, that's why hormonal contraception is contraindicated, right? We know that hormonal contraception increases the risk of DVT, right? It affects coagulability and clotting. So the other thing we really don't want to have, if possible, is an IUD. IUDs are pretty safe these days, but it does increase the risk of PID, pelvic inflammatory disease. And remember, they have neurogenic bladders, they're wet, they have skin issues. So it's probably not a good idea to have an IUD. Which leaves what?
Condoms.
Barrier protection, which is condoms and diaphragms. Something to keep the sperm out, right? So condom and diaphragm, probably both. The diaphragm prevents the sperm from entering the uterus, does not prevent sexually transmitted diseases. Okay? So barrier protection, something like a diaphragm. And the last thing I want to say is that it's a major life loss. So coping with their non-paralyzed, pre-injury, ambulating self is a huge thing. So it's just like some part of they're grieving the loss of their pre-disabled self. And you know the stages of grieving. Been around for many years. Everybody goes through it differently and in different orders. Some people stay in the first stage of denial for a long time, maybe forever. We don't take away hope. That's their choice. We also don't give false hope or be overly pessimistic. So if the patient says, God's going to give me a miracle and I'm going to walk out of here, you know what? There's two things you don't do. One thing you don't do is you say, oh yes, God's going to give you a miracle and you're going to walk out of here. That's not therapeutic. You also don't say, oh, I saw your x-ray and CNS tissue doesn't regenerate and you're like this and this is complete cord transection and there's no possible way. You don't do that either. You do therapeutic communication, you reflect, you let them talk, and you maybe get them some kind of counseling. And there's some good group counselings that help very much. If they're angry, patient throws the tray at you, it's normal.
So you let somebody else tell.
Yeah. Well, you do let them have their coping because they're going to come around to it. They will. They'll go through the stages. They'll have denial. They may have some anger. They may bargain. If you let me do this and that, if God gives me a miracle, I'll stop hanging on the street with my buddies selling drugs. I mean, those people are whoever they were before they got shot or before they ran their motorcycle into the tree. So they still are going to go back in the community they came from. And then maybe some sort of acceptance. And I don't even think acceptance is a good word. I'm not sure I would accept being a quadriplegic. Maybe adaptation or adapt is a better word. Adapt to the reality and do the best you can with what you got. That would be a good goal. All right, your case studies, go back over them. Everything that is in your study guide. We'll do the case studies the very first part of next Wednesday. Charlie is right here with the competency. Charlie was my patient. And then there's a couple others in the back. There's Scott, who's the young guy I mentioned who was, became a paraplegic in a skiing accident. Bev, who was in a car accident. Neil, who fell off a roof. And Jeff, again, real story, was a teacher, and he broke his neck on the top of the water. It wasn't even like he was drunk and dove into 3 inches of water. He actually was doing a regular head-first dive, and he snapped his neck forward, freak accident, and became a high quad. Wonderful family. He actually did go back to teaching with a personal care assistant with him in the classroom. So the better people function before their injury, the better their outlook for things after the injury in terms of their psychosocial and vocational adjustments. People go back and become attorneys and rehab counselors and that kind of stuff. But again, they have to have the intellect and the support systems in place for that. All right. Questions? I have lots of information, but you probably have enough. This is from the Spinal Cord Medicine clinical practice. This is a professional one. Neurogenic bowel, what you should know, guides to people with spinal cord injuries. There's all kinds of information now online, Gone are the days of just booklets. The American Spinal Institute Association, or ASIA, ASIA, has a lot of stuff. There are guidelines for care, guidelines for short and long-term goals for rehab. A lot of that is fairly recent. Believe it or not, the guidelines for care of a patient with spinal cord injury came out in the early part of this century, meaning 2000, 2002, somewhere in there. So it's still evolving. Some of you, but it's a great area for employment. It was my first job in nursing, was in Boston on that spinal cord unit. I think it's still, at this moment in my life, it was my very favorite job. The nurses bonded, the patients bonded. We were all the same age, so that helped. But it was a really great way to have long-term relationship with patients. Has anybody ever worked at National Rehab or gone there for clinicals or any of that sort of thing? We used to go there for PEDS clinical. They have a PEDS unit now. We just lost that last semester. They got burned out with too many nursing students. That's what happens. We have so many schools around D.C. that they get burned out and they say, no more.
I did a rotation on a rehab floor
Okay.
at my old school, and that was my favorite floor to be on.
Yeah, you really get really close to the patients. And a lot of, the new grads now that I've talked to have started in the May grads. The ones who have been employed as RNs are going to long-term care facilities who now have rehab units and are hiring more RNs to run these and work on these rehab units where patients come from multiple trauma, ortho surgeries, strokes, etc., and they go to those kind of rehab. That's the subacute rehab, and those are areas of employment as well. Okay, take a break. Come back in 10 minutes, and that'll give you a full hour. I'm not going to snatch anybody's paper out of their hand at 11:30, but some people do have class at 12, so I want to give you the full hour. Okay, so go take a break. Go take a break. Get air, get water, get bathroom.
Oh, okay, thank you.
Do your deep breathing, whatever you need to do, and come back at 10:30.
Are we going to use our own calculator?
I have calculators. No, you're going to get everything from me. No fancy
Oh, I didn't get the
calculators.
sign-in. Is that the sign-in?
The sign-in's on a clipboard. Where'd it go?
I never got it.
Who has the
I didn't sign in.
clipboard? It's right there. Right there.
Kilograms per hour. Sometimes I don't know how they got two.
Yeah, like our
Because I keep getting.
Oh my goodness. No videos.
There's something wrong. There's something missing there. There's another page. I'm thinking, wait a minute. I see what you got, but what do you need?
Yes,
Yes.
that's right. Over 1 hour.
Say next. Yeah. Well, you can't do that. Don't worry about the one that says it's for the instructor. There is one specifically for the software. Sign that.
I'm at 22 when I do it.
Everything is where it says sign. Please sign. Oh, okay. Okay, this is
So
number
I will
9.
use the answer this for
Number 10. Oh, okay. Yep. Yeah, you don't really need to know this because you're not a traveler. Fill that out. So it's 2 pages. All right, now. Okay, so we're going to give 0.5 grams, which is 500 milligrams.